Hello, my name is John Pemberton, diabetes dietitian and creator of the Glucose Never Lies, the education program just in case my kids, as you can see here, get type 1 diabetes in the future. I've been presenting across the globe with regards to the automated insulin delivery systems and exercise management for type 1 diabetes. So I've been delivering this stuff to healthcare professionals, but obviously the people who need this information the most are the people with diabetes or the people who are supporting people with diabetes. So I've tried my best in the next 25 minutes to summarize everything that I know into hopefully something takeaways that you can discuss with your healthcare provider to improving the glucose management during exercise. Very important to say, I'm not your dietitian, I'm not your doctor, I don't know you, so it's important that this is for informational purposes only, and that if you want to try anything that's within here, please discuss with your healthcare team. I'll keep mentioning that, but that's really important because your healthcare team will know you as an individual. What we're going to go through is, first of all, just a quick discussion about continuous glucose monitoring, making sure that the system that you have is accurate, because these automated insulin delivery systems are driven by how accurate the continuous glucose monitor is. If the continuous glucose monitor is accurate, you're going to have a good experience. If it's not very accurate, you're going to have a poor experience. And these dots on here, what do they actually mean? Well, these basically mean people who have continuous glucose monitoring generally have about 60% time in range from the studies. If you had a system that had a predicted low glucose to spend, maybe you get 65, but these new automated insulin delivery systems that when you go high, they give extra insulin, and when you're going low, they take extra insulin off, on average are achieving this magic mark of 70% time in range, and some more. So there's a massive leap. So these automated insulin delivery systems are really changing the game for people with type 1 diabetes. However, exercise is the biggest challenge they face. These automated insulin delivery systems are unbelievable overnight, because all you have is you're asleep, and all you have is the insulin going up a little bit when the glucose starts to rise a little bit, and when the glucose starts to fall, it takes a bit off, and it works beautifully. However, during the day, if you do a lot of exercise, you may drop quickly. Stopping the insulin isn't going to work quick enough. You need extra carbohydrate or to pre-plan reducing the insulin before then. And similarly, if you go really high because you didn't eat a meal, obviously, giving the insulin is not fast enough to manage that. So these systems are amazing, but they do have limitations, and exercise is one of the biggest challenges that these systems face. Hence the need for a session, which hopefully will give you some insight into how to plan or how to provide extra carbohydrates if you are dropping. So we're going to talk about how to structure a plan, talk about these systems, and then hopefully leave you with a few resources to think about discussing with your healthcare team if you decide that some of these resources might be useful for you. Just important to recap, again, continuous glucose monitoring. When you do a finger prick and a blood glucose monitor, you're measuring the glucose that's directly in the blood. A continuous glucose monitor is measuring the glucose that's in the interstitial space, or like I got to call fat tissue. But you can see there's a 5-minute lag at rest. Now, what you can see here is the difference when you're at rest up here before the exercise starts. There's very little difference between the blood glucose in red and the sensor glucose in black. But once you start to exercise and the glucose starts to drop rapidly, you can see the blood glucose drops faster than the sensor glucose, because this time lag goes from 5 minutes to about 15 to 20 minutes for several reasons that you don't really need to know, but exercise means that the time lag increases. And similarly, just as described, if you have a load of sugar then to treat this, or glucose, then you'll go high very quickly and the blood glucose will be higher than the sensor glucose until it steadies out. So when the glucose level is changing rapidly, the sensor accuracy drops off, and obviously we know the sensor accuracy, well, the sensor results are the things that actually drive the automated insulin delivery system decisions. So it's just to say, this is one of the reasons why the automated insulin delivery systems struggle to manage exercise sometimes, because of these rapid changes. And one thing to think about with that is, these are the reasons why the time lag increases. I'm not going to go through them necessarily because it's not necessarily needed, but what is worth thinking about is during exercise and activity, you might want to set your low alert a little higher because the sensor might be reading a bit higher than you actually are. If you have double arrows down and you're moving very quickly, you really might want to think about testing your finger prick rather than rely on the continuous glucose monitor. There is nothing wrong with that. As I've said, these automated insulin delivery systems are unbelievable at managing overnight, in between meal times, but during exercise when the glucose is moving rapidly, if you've got 2 hours going down, you might want to think about testing your finger prick with a blood glucose, especially if you're in that lower range towards hypos. So this is just to sort of let you know what the arrows mean for the different systems depending on which one you're using. But essentially, if you've got sort of a double arrow down or a straight arrow down, the glucose is moving at least 1.5 millimoles per litre quicker, or about, what's that, 30 milligrams per decilitre it's dropping at in the next 10 minutes. And similarly, if you've got arrows up. So it's just really to think about with these automated insulin delivery systems, if you've got double arrows going down and you're towards the hypo range, it might be worth thinking about doing a finger prick just to make sure you're not actually low, especially if you're thinking about how much extra carbohydrate you may need. So again, these systems are unbelievable, but exercise poses a challenge because rapidly falling glucose levels during exercise means the difference between the sensor and the blood glucose will be a little bit higher. Okay, so now that we've talked about the challenges, let's think about what we need to plan for with making an exercise plan. Well, we need to know what you actually want to do. Is it you want to get fitter or lose weight? The intensity of the exercise, the type, the basal insulin conditions, how much insulin you've got from boluses, is it planned, is it unplanned? And then we've obviously got to think about extra carbohydrates depending on where the glucose level is and where it's going. So there's quite a bit to think of, but we're going to break it down step by step and give you some thoughts about how you can plan. So the first thing is thinking about the type of activity you're doing and what you should or what would you usually expect to happen with your glucose level during the activity. So this is a recent paper by Mike Cradell and Ann Peters, really nice paper that updates the type of glucose expectation from the different type of exercise. If you're doing endurance exercise at one steady pace, what we call aerobic exercise, you will generally expect a drop in glucose. How much depends on several things, mainly how much insulin you've got on board, but you'll generally expect a drop. If you're doing something explosive like powerlifting, like judo, like sprinting, you will often find that the glucose level will increase, especially if you're just under, you don't have any insulin on board from a recent bolus from food. You can expect it to go up quite a bit, and that's because of the stress hormones pushing the glucose level up. Now, most people, or a lot of people, do HIIT exercise, some hard, some relaxed, some anaerobic, some aerobic. Sports, including football, netball, basketball, are all mixed between these moments of sprinting with these moments of aerobic activity. And the glucose level may go high, or it may go lower, or it may stay exactly the same, depending on how many sprints you're putting within there. And then resistance training is very similar to HIIT training in that you could go higher or you could go lower depending on the intensity of the session, how many reps, how many sets you're doing. So for example, if I did a leg day where I was not doing many sets, but I was going all out and really stressing my big muscle groups, I may be expecting a higher rise in glucose. If I was doing maybe a chest and biceps day for the beach with lots of sets and reps, then maybe I would expect a glucose decrease, but you would have to see how you were going. One of the biggest considerations, and we're going to spend a bit of time when we come to planning, is when was the last time you ate, and was it when you gave insulin for that meal, obviously, and was it within the last 2 hours? If it was in the last 2 hours, then we probably need to think about planning of reducing the amount of carbohydrates you enter into the automated insulin delivery system to reduce the insulin that's given, to make sure there's not too much insulin on board when we start the activities. If you start aerobic exercise with a lot of insulin on board without doing any insulin reductions, you can expect this to happen, a massive drop in glucose. Whereas if you reduce the insulin, you maybe expect something more like this. Similarly, if you're doing a game of football and you haven't reduced the insulin, you can expect it to be more like this. If you have reduced the insulin, you can expect it to stay stable or maybe rise a little bit. So you get the idea that knowing how much insulin on board from your previous meal is absolutely key. And if you're going to be eating given insulin within 2 hours, really thinking about reducing the carbs that you enter into the system that you have, so there's not too much insulin circulating when it comes to an activity. Now, in an ideal world, to get best control with diabetes management, you would want to do the activity 3 hours after eating. Therefore, there'd be very little insulin left from the bolus that you've given previously, and you'll be operating under basal conditions. And that means that really the glucose level stays a lot closer to staying stable, because under basal conditions, there's not as much glucose variability afterwards. So these are two really important things. Know what type of activity you're doing and know how much insulin you have on board. You know those two things, you've got a good idea of what's going to happen to your glucose level and gives you a real good opportunity of what to plan in terms of insulin reductions or extra carbs. After exercise, what we do need to think about is the risk of going low afterwards. So this is a classic study, I say classic study if you know studies, where effectively they did 45 minutes of activity at about 4 p.m. and they put people on a constant level of insulin, and then what they did was see how much glucose they needed to keep the glucose level stable. Basically, seeing the level of insulin sensitivity during and after exercise. So before exercise, it's kind of normal, and then during exercise, the amount of glucose that was required to be infused was a huge amount because of the insulin sensitivity went up, or the glucose uptake from the muscles was very greedy, and that remained elevated for the next hour or so afterwards. So we have to be careful with the insulin that we give for a meal afterwards. Then it stayed fairly steady for about the next 5-6 hours. Then 7 hours later, which was overnight in this case, you can see the amount of glucose that was required really increased because the muscles and the liver were sucking glucose back up into the liver, back up into the muscles. So we have to be careful here. Now, the beauty of an automated insulin delivery system is previously on a pump or injections, you had to plan for this and you had to think about reducing background insulins, having snacks before bed. These automated insulin delivery systems are amazing because they pick up the fact that the glucose level starts to drop and just reduce the insulin. So the beauty of these systems is you still need to consider reducing insulin afterwards, but this kind of overnight situation, you can actually let the system take care of it and get a beautiful night's sleep. This is just to say the automated insulin delivery system journey has been a long way from this, the start of insulin through to insulin pumps, through to insulin pumps talking to continuous glucose monitors, through to now where we're getting to actually commercially available automated insulin delivery systems such as the CAMS APS, the Medtronic products, the Tandem products. There's fantastic ones available, and there's also a set of DIY ones that the We Are Not Waiting community have really worked hard and produced some excellent things that a lot of people are using as well, and I'll try my best to incorporate a bit of that within here, but I have to be honest, my knowledge of those is not as good as it is for the commercial systems. Whoa, now this looks heavy. The only reason I put this in is because if you're a healthcare professional or you're thinking about selecting a system, there are a lot of things to consider, but probably the most important thing to consider is what can the user, the person who's using the system, adjust to change how the algorithm works, to change how this system ups and downs the insulin. So you've got some systems, like the Medtronic systems, where you can't really change a great deal. The only thing you can change is your carb ratios, the activity modes, and the active insulin time. So the system really does a lot of the thing for you, but you can obviously change the target range, which we'll discuss. And then you've got the opposite end of the system, where you've got the tandem control IQ, where the user actually sets the basal rates, sets the correction factors, sets the carb ratio, so is very much in control of how the algorithm is working, which gives them a lot of flexibility during exercise, but at the same time there's a lot more room for error. And a lot of the DIY systems operate on this, where you set the basal rates yourself, the correction factors and sensitivity, which is fantastic for the people who really understand it, who are in control and want that fine-tuning control. Maybe not so useful for people who don't have that in-depth understanding and want the algorithm to look after those things for them and they can just crack on with their life. So this session is not to kind of go through these in detail. There's a section on the blog that will help you think through this, but this is just to say for today, I've highlighted this because I'll be discussing some of the options you can manage with exercise. But if you're an absolute nerd, this is the paper to go and read. It's got everything laid out for you in terms of how the algorithms works, etc. Okay, when it comes to exercise, the things that these systems offer, which is fantastic, is normally the system aims to get your glucose level to a predefined level. So if you're on a 670G, 6.7 millimoles per litre, 780 you can decide, but usually most people aim for 5.5. T-Slim sort of aims to get you to 6.3 or between 6.3 and 8.9. The CAM's at 5.8, but you can adjust it. Omnipod 5, you can be for anywhere between 6.1 and 8.3, and then the DIYs, you're up to you where you want to set it. So wherever you want the system to get your glucose level to, this is where you set it. But the beauty is they all have some kind of activity target where you can temporarily increase where the system aims to get you to. For example, usually pushing it up by 2 or so that the system is not as aggressive with the correction insulin it puts in, and it cuts out the insulin sooner when you're dropping. So that's the beauty of these activity modes. They basically keep you away from hypoglycemia for a predefined set time during the exercise. So it's important to set this exercise target, ideally 90 minutes before you start, but realistically just get it on before you start, so that we don't end up with a system pushing too much glucose in if you happen to go high during exercise. Okay, so a big question is, will these systems, if you put this exercise target on, will these systems with that exercise target on stop you from going low, even if you've had insulin in the last 2 hours? Well, this shows us the answer is absolutely not. So this study took 39 adults and they got them to do the same exercise 3 times. They had 65 grams of carbs for breakfast here, and then a couple of hours, 90 minutes later, they started to exercise. The first time they did this, they didn't do anything. They just gave their normal insulin. They didn't put the exercise target on. You can see in red here, they went a little bit higher, but then a lot of them were hypo, as you can see, by about 30 minutes into the exercise. And this is, for the people who did that, pretty much everyone had at least 10% hypos, 20% hypos, some were even hypo the whole time. So if you don't put an exercise target on, or you don't put an insulin reduction on, you're going to be in trouble, which you obviously know. But then the next question is, in here in the grey, if you give the full insulin but just put the exercise target on, does it protect you? And the answer is no. It almost performs exactly the same as if you gave you didn't put the exercise target on at all. And the reason for that is the bolus insulin, because it lasts for say 4 to 5 hours, is still working heavily in the system here. Hence a lot of the 39 people experienced significant hypoglycemia. Now, if you did a 33% reduction of the insulin as well as putting the exercise target on, yes, you did go a little bit higher in 90 minutes time. However, only 1, 2, 3, 4 of the 39 adults actually experienced hypos. So the moral of the story is, yes, if you're going to be doing activity within a couple of hours, or certainly 90 minutes of activity, you're going to need to be thinking about an insulin reduction. Maybe not 50%, but kind of 33%, 25, 30% would probably be about right. Backing that up, just to kind of go in through one more, is it safe to leave it 2 hours? Because there is a theory that if you give the insulin and reduce it by say 30% 2 hours before, that you'll end up going really high, the system will kick in and push loads of extra insulin in, and they'll end up coming flying down low during the exercise. So this study looked to do that. It took 13 adults. Just before breakfast, they did a 33% bolus reduction, just as in the previous study. They put the exercise target on just before exercise, and then on the first day, they did the exercise 1 hour after breakfast. And on the second day, the second time they came in, they did the exercise 2 hours after breakfast. And we have a look at what happened to the differences. So if you do it 1 hour after breakfast, you get more time in range than if you do it 2 hours afterwards. You don't experience more time above range, above 10. And you don't have any hypos. So they basically both perform really well. What was potentially a worry is that if you did it 2 hours before and you went a bit higher during the exercise, the algorithm would push loads of extra insulin and you go hypo. That doesn't seem to be the case. But what is to be expected is if you wait 2 hours, the rise from breakfast to starting the exercise is actually about 4 millimoles per litre, whereas if you do it within the hour, it's less than 2. So I guess the moral of the story here is it's absolutely fine to do an insulin reduction on these systems and wait 2 hours before you do the exercise. Not a problem. It's not going to cause you hypos, and you're not going to have any issues. But if you want more time in range, you'd probably want to only wait an hour, and that way then you would get more time in range and you also don't have the same level of hypos. Now, this is obviously for moderate intensity activity, but again, it's nice to see that this research is being done, which is kind of telling us you can wait up to 2 hours, and we're looking at about a 25 to 33% reduction in insulin. I like to think in terms of 25% because it's much simpler to work out, and how you do the insulin reduction is you just reduce the amount of carbohydrates that you're putting into the system, which will automatically reduce the insulin, rather than fiddling with the insulin doses. This is probably something that is only just being recognised now. So we've talked about you need some insulin reductions before, but what about afterwards? What happens when you put the exercise target on here? So you can see in a 670G, the exercise target's been put on here. And as we said before, what that means is the algorithm shuts off the insulin much faster. So you can see here, the basal insulin is the kind of the little pink rises. As soon as you put that exercise target on, there's hardly any background insulin, which really helps during the exercise. But then when you finish, if you do your usual plans of reducing the insulin by 50% afterwards, there's such a lack of insulin around, you often go really high. So this is one example on a Medtronic product. And then this is another example with the tandem control IQ. Again, going along here, exercise target put on, pushes the target up to about 8.9, I think. Therefore, it's below 8.9. The system turns off the insulin, as you can see here, for a good 2.5 hours, manages the exercise nicely. The usual bolus reductions of 50% were given, and the glucose level went really high. So I guess the thing to think about is when you put these exercise targets on, it's going to suspend the insulin often for longer periods than you're used to, which means when you finish, there's not going to be much insulin around, and then you're going to have to think my usual plans of reducing the insulin by 50% are going to be too much. Maybe we only need to reduce the insulin by 25% afterwards. Pretty simple. I mentioned before that if you do exercise after 4 p.m, there is a risk of going low during the night, and previously on pumps and injections you need to think about reducing the background insulin overnight. So I guess the question the research asked was, do you still need to think about that when you're on one of these systems? And the answer appears to be no. So they did here where they did some vigorous exercise after the evening meal, and then they looked at what happened during the overnights when they just let the algorithm work completely on its own. And then they looked at the nights post-exercise versus the nights where they didn't do exercise to see if there was any difference in hypoglycemia. And interestingly, there was actually less hypoglycemia on the nights where there was exercise compared to the pre-nights. I wouldn't read too much into that other than to say you don't need to leave the exercise target on overnight. You just let the system run by itself and you'll actually be fine overnight. You don't need to leave the exercise target on and prolonged push it up overnight. So again, that takes away quite a lot of the worry and concern when you have type 1 diabetes. Am I going to go low overnight? Will these systems cope if I've done exercise in the evening? And the answer appears to be yes. So you can actually safely go to bed and not put the exercise target on. Obviously, if you do experience hypos when you do that, then stick the exercise target on overnight. But this is just to say, as a standard, you probably don't need to. Whoa, okay, so this is a table which I'm going to talk through very briefly and show you something that we've adapted where I work by Dessi, Zaharieva, really nice lady, great researcher from the States at Stanford, and she sort of put down the type of things you would do in open loop mode where the automated insulin delivery system isn't working, just like in pump therapy. For example, bolus reductions before, as we've said, bolus reductions afterwards, 20% basal reductions overnight, all those things we discussed. But what should be different on closed loop? And the key things are trying to start the exercise target, as we discussed, 1 to 2 hours before you start. Don't be as aggressive with the insulin reductions. Stick to 25% insulin reductions rather than 50% insulin reductions, as we previously discussed. And then put the exercise target off overnight, which is, again, as we've sort of said, because you don't need that on overnight. So she summarised that quite nicely of the differences between open loop and closed loop control, and that's always worth having a look at. And the other thing to consider here, which is mentioned, is rather than giving, if you're about to start exercise and your glucose level was say 6, previously you may have given an hour's worth or 50 minutes worth of carbs before you started to get you through the hour. So it might have been 30-40 grams of carbs. The suggestion is try not to do that on an automated insulin delivery system and only give carbs for 20 minutes at a time, so you don't push the glucose level up high, which would then cause the system to pump loads of extra insulin. So keep your supplementary carbohydrates in sort of 20-minute blocks rather than in an hour's worth at a time. I'm about to show you the table that we use where I work. Before I show you that, is just to say that the table is based off very limited research because there hasn't been a great deal of research within this area. And the research that there is, as I've just shown you on previous ones, you're looking at studies with only 30 people or 15 people. They're generally adults and they're generally done in controlled lab conditions. There are loads of reasons why the glucose level behaves very differently from day to day, even if you follow the same plan. Such things as how much insulin's on board, how your fitness level, are you someone who's still honeymooning? So this is to say, if you look at a table and you're going to try a plan, fingers crossed it'll be better than doing nothing, but don't expect it to work perfectly and don't expect it to repeat exactly the same every single time. There are a lot of reasons why glucose control is very difficult with activity management, and these are some of the reasons that you can look through there. So this is what we use for eye work. As we said, look at the exercise type first. So let's just say we're going to use here a game of football. You'd look at the starting plan. So if you're going to be doing the activity within 90 minutes or 2 hours, ideally keeping it within 60 minutes, you would reduce the insulin by 25% and you would turn the exercise target on. So just as we just discussed before, 25% reduction, put the exercise target on. And then after you finish the exercise, only do a 25% reduction of insulin, and you achieve this by reducing the carbs you're eating by 25%. So as a simple example, if I was eating 100 grams of carbs before, I would take 25% off of that. Now, obviously, you'll know that that's take 25 grams off, but a simple way of thinking about it is half and half again gives you 25%. So 100, half of that is 50, half of 50 is 25. That's how you know it's 25%. The maths are pretty simple. And you can even do the same if it was 50 grams, you go, what's half of 50? 25. What's half of 25? 12 and a half. So you would put 12 and a half grams less in if you were having 50 grams. So that's just a simple tip. If you're not very astute at doing percentages, that's an easy way of working 25%. And the key thing here, as we said, once you finish the activity, turn the exercise target off because the system should be fine to manage that overnight. So there's just a simple table depending whether you're doing aerobic, mixed or anaerobic exercise. And the key things here is, again, if you're going to be having extra carbs during, keep them in 20-minute blocks, don't preload. And obviously if you're taking the pump off, make sure you suspend the pump because the pump or the system doesn't know that you've taken it off and it still thinks the insulin that it's delivered is going into you. Therefore, it takes that into account when it's making its decisions. So really think about suspending the pump if you're going to be taking it off. At the end, you can get hold of some resources that you can speak to your healthcare professional about, which basically you can pop in who you are, what you're doing, obviously if you're in auto mode, how many minutes before eating, what are you doing, and what it will do then is spit you out a plan to tell you, just as we discussed here, reduce the carbs by 25%, put on the activity mode, have this amount of carbs every 20 minutes depending on your glucose level and trend arrow, and then what to do afterwards. So that's a simple way of taking these rather complicated tables into something that's usable, but that needs to be done with your healthcare professional, obviously. If you want to know how many carbs you should have, this is a fairly simple table to follow. This basically says where is your glucose level and how many additional carbs should you be having. So if you're between 7 and 15, possibly don't need anything. If you're between 5.7 and 6.9, an additional 15 carbs. If you're between 3.5 and 5.6, an additional 20. So that's if the glucose level is stable. However, if the glucose level is going down with a double arrow down, and let's say it's 6.8, you would just double that and you would have 30 grams. On the other side, if you had a double arrow going up, you wouldn't give any. If you were 5.5 with a one arrow going down, you would increase that by 50%. So you would go for 30 grams as opposed to 20. So this is just a simple way of thinking. If you know what you usually have in terms of carbs, so say 20 to 30 minutes, if you've got double arrows down, then double it. If you've got double arrows up, don't have any. If you've got one arrow down, you'd probably only have a half extra. If you're one arrow up, you would only have half of what you usually had. So that's just a simple way of thinking about carbs. You will still need carbs during activity, even if you've done bolus reductions, even if you've put the exercise target on, because if your glucose level is a 6 with a double arrow down, and you've still done those things, you're going to need extra carbs. But the glucose value and trend arrow should allow you to make better decisions. Just going to skip past those. To say one final thing. So one final thing here is if you're someone who's gone from using a pump or injections and you had plans that worked perfectly to manage exercise, and then you've gone on one of these systems and all of a sudden it's really difficult to manage and your glucose control is absolutely all over the place, there's a good reason for that. And this happened to me when I tried all of the systems, and it's why I personally don't use one at the moment, although I'll probably end up using a system and put the closed loop on overnight and then go back into control during the day. Is because if you do a lot of exercise, you can never really know what the basal insulin conditions are. And I'll give you my examples for me. So I cycle into work and I cycle back from work every day. It's 45 minutes. So when I'm on a pump, I know that my basal rate going in stays exactly the same overnight when I'm not on a system. So when I wake up in the morning, I don't have breakfast, I cycle in and I know that it's only 10 grams of carbs to get me in. However, if my glucose level had been going higher during the night a little bit and the system had been putting extra insulin in without me really knowing it, I only have my 10 grams carbs. Within 20 minutes of the cycle, I ended up going really low. And the same happened in the mid-afternoon. I'd always cycle home at 5 p.m. In the middle of the afternoon, my glucose level was say 7, which I was happy with. But the system would be putting extra insulin in to push my glucose level down without really me knowing. I would hop on the bike thinking my normal plan of 30 grams of carbs in the afternoon would get me home, and it wasn't enough and I would go really low. So because the systems are always upping and downing the amount of insulin that's in your system without you really knowing, you can never be certain of the basal insulin conditions. So it can make it really difficult for people who've got precise activity plans that they know are effective when they've got a certain level of basal insulin. So there's absolutely nothing wrong if you're experiencing that and you're really having trouble with just turning the automated insulin delivery system off 90 minutes before you start your activity, and then just go back to open loop control before the activity, manage the activity, and then slip it back on afterwards and get the best of both worlds. So just as I said, what you can do if you want to do that is go into open loop 90 minutes or 2 hours before exercise and you take back control of the basal conditions. But a couple of things to make sure if you're going to do that is if you're using a system that doesn't run off the manually set basal rates, you will need to make sure that those basal rates are updated, for example, in any of the Medtronic products, in a CAMS product or an Omnipod 5. But if you're on a Control IQ, you will already have your basal rate set correctly, so that will be fine. If you're going to do this, try and make sure you had your last meal and bolus insulin 3 hours before, so you've only got basal insulin conditions working. And then obviously you will need to do some observation and adapting as you go. But the key thing is you can just put the closed loop back on as soon as you finish and get the benefits of the control afterwards while you take back control during exercise. There's absolutely nothing wrong with doing that, but obviously you would need to speak to your healthcare provider before you did that, making sure the key thing is that your manually set basal rates are set correctly for you, so that you know what the basal conditions are. Okay. Summary. So in summary, remember that continuous glucose monitoring accuracy does deteriorate during exercise. So if you're dropping and you're towards the hypo range, there's nothing wrong with using your blood glucose meter, especially if you've got double arrows down, and using that to make your decisions. And in terms of arrows, obviously think in terms of 10 minutes and how many carbs to have. You can, again, if you've got a double arrow down, you'll need double the amount of carbs that you normally have for that 20-minute block. If you've got a double arrow up, you'll probably need none. Single arrow down, you probably need half more of what you usually have. If you've got one arrow up, half of what you usually have. You can go have a look at the Automated Insulin Delivery System guide on the Glucose Never Lies. And then the key thing in terms of exercise plans is previously people used to do 50% insulin reductions before, 50% insulin reductions afterwards, and then basal reductions overnight. The difference with the automated insulin delivery system is turn the exercise target on before exercise, only do 25% reductions if the exercise is within 2 hours, only do 25% reductions afterwards, and turn the target off. So that's a solid place to start with your activities, and drip feed the glucose as you go in. If you want to get hold of any of the calculators or the resources, hold your phone up to here and you get the QR code that will take you through. Obviously discuss those with your healthcare professionals before considering any of the plans that are on there. And yeah, that's kind of half an hour deep dive into where we are with the kind of the research and planning for automated insulin delivery systems and exercise. Yeah, thanks for your time.